Here's one you've probably never seen before. This is called Smith-Lemli-Opitz Syndrome. It's not tremendously common in the general population. However, it is common among Europeans, particularly Northern Europeans, people of Northern European descent. Where I practice in Minnesota, we have a very high Scandinavian American population, and so this is a little bit more common here than probably elsewhere in the U.S. Or in the rest of the world, for that matter. So we'll go ahead here. We'll just do a quick overview of what this is, and then we'll delve into the genetics. We've only gotten a really good understanding of what this is genetically within the last 15 years, and so there's some things that you probably haven't heard of before that are associated with this syndrome that's worth reviewing, especially if your training was longer ago. So this is an autosomal recessive disorder, meaning that a lot of times there's not going to be an established family history unless the couple has had more than one child. It's characterized by a distinct facial appearance, which gets more distinct as the child grows up. Usually 2, 3, 4 years of age is when it becomes quite distinct. But a lot of times you'll be able to tell this diagnosis right away when the baby is born based on the characteristic appearance of their nose, which is hallmark. There are some other things that are associated with this disorder, including microcephaly. They tend to track around the 3rd percentile or lower from birth. There's also some severe feeding issues that revolve around this disorder, in part because they have a small stomach, but also because they're at higher risk for pyloric stenosis. There tends to be a global developmental delay, both particularly in the gross motor development as well as in cognitive development. Most of them tend to have cognitive defects, intellectual disabilities, and then genital anomalies are also implicated. The incidence is estimated to be about 1 in 20 to 70,000, but that really depends on where you're practicing. So in the Czech Republic, for instance, there have been studies that have shown it to be 1 in 10,000 or possibly even more. In areas of Africa, Asia, it tends to be quite rare. The genetic basis to this is a mutation of DHCR7, which codes for a protein with the same name. The gene is found on the long arm of chromosome 11, and it codes for an enzyme that converts 7-DHC to cholesterol, which is the final step in the cholesterol synthesis pathway. The result, if you have a deficiency in this enzyme, is going to be low levels of plasma cholesterol as well as dramatically high levels of 7-DHC. And the symptoms of this disorder, the manifestations of this disorder, particularly neurologically, are associated due to toxicity of 7-DHC as well as the low levels of cholesterol. Hedgehog proteins, including sonic hedgehog, Indian hedgehog, and desert hedgehog, are implicated in the pathogenesis because cholesterol is necessary to convert inactive hedgehog protein to active hedgehog protein. And so when you think about sonic hedgehog protein, which is very well studied, you think of particularly the midline and structures of the midline and defects of the midline if you are deficient in the active form of sonic hedgehog protein. And indeed, when we look at some of the manifestations of this disorder, where you have a deficiency in active sonic hedgehog protein, you will see many of the midline defects, including of the brain, of the corpus callosum. You can see holoprosencephaly in a minority of these patients, and also issues with the nose, of the palate, and so on. Like I said, this disorder is seen primarily in those of European descent, and that's probably because there's a heterozygote advantage to having one mutated form of the DHCR7 allele and one normal form, similar to how we see the prevalence of malaria in Africa classically by having one mutated sickle cell allele and one normal allele, because that provides protection against malaria. What we've found is that there is a heterozygote advantage to having one mutated DHCR allele because it increases vitamin D bioproduction. And what we've seen in anthropologic studies is that rickets was really a problematic pediatric disease early on in human development in Europe. And so having that enhanced vitamin D bioproduction increases your survival opportunity. And what we also see in children with Smith-Lemli-Opitz syndrome is that they tend to have a fair complexion, fair appearance, so these homozygotes tend to be hypopigmented and particularly photosensitive, and of course that's going to increase vitamin D production. So this is just an example of how cholesterol is necessary in the activation of sonic hedgehog, but also in the activation of the other hedgehog proteins as well. Now, when you look at what sonic hedgehog as well as desert and Indian hedgehog proteins do, you're going to see how this manifests the symptoms of SLOS. So sonic hedgehog is important for midline development, particularly ventral midline development. Desert hedgehog is implicated in genital and gonadal morphogenesis, and Indian hedgehog is implicated in limb development. And indeed, in Smith-Lemli-Opitz syndrome, we have defects of the midline, we have defects of the genitals, and we have defects of the limbs. And so this is probably due to the fact that there is, because of the low cholesterol levels during fetal development, we have reduced activity of the sonic hedgehog and other hedgehog proteins. This is just an example here of how this disease is caused biochemically. There are a lot of different disorders that are involved in the cholesterol biosynthesis pathway. This particular disorder is due to the 7-DHC enzyme deficiency, and so it's down here. The features that you're going to see in SLOS are vast. However, I highlighted the more important ones to remember in red. So these children tend to be short, both at birth, low birth length, and on into adulthood if indeed they survive that long. They also tend to have feeding difficulties. That's basically a universal feature of SLOS. And they also tend to be hypotonic, which is likely the cause of their delayed gross motor development. Craniofacially, you're going to see some very distinct features, and this is going to really help you in your diagnosis. They tend to be microcephalic with bitemporal narrowing. That's not particularly this isn't the only syndrome that has that, but it's something that you will see universally. They tend to have ptosis. Unilateral is more common than bilateral. Their nose is very distinct. So they have a broad nasal bridge and base, very short nasal root, and anteverted nares. So they have really the classic button nose. So very small nose, wide, and the nares are anteverted, and so you can very easily see the nares when you look at these children. Because they have a small nose, they're going to consequentially have a long philtrum. They have low-set ears in many cases. That's something we see very common in genetic disorders. If you have a child with low-set, mal-rotated ears, they probably have some kind of genetic disorder behind that. Micrognathia can contribute to the feeding problems. They also tend to have large mouths with widely spaced teeth. And in utero, if you do sonography, a lot of times you'll see a cystic hygroma. The result of that is going to be a short neck with redundant skin. They do have skeletal manifestations as well. Bilateral or unilateral polydactyly can be seen. You can also see syndactyly, either bone syndactyly or cutaneous syndactyly, and this will be particularly seen between the second and third digit. So the classic Y-shaped cutaneous syndactyly is seen in a majority of these cases. Their thumbs can be abnormally placed. They tend to be short and proximally placed if there's abnormalities there. Pretty much all of these children, there are going to be neuropsychiatric manifestations. Most of these children will fit the clinical criteria for autism. They also tend to be hyperactive, and they can also engage in self-injurious behavior. Uh, the classic self-injurious behavior that's defined is well, it wouldn't be epistotonous. Can't remember how the authors described it. Epistokinesis, where they're essentially assuming that epistotonous form, uh, back arching. There can be head banging and gnawing of the hands and arms. There's global developmental delay, particularly in gross motor development, but they also tend to have intellectual impairments. And then you can see brain malformations. If you look at an MRI, there tends to be large ventricles, as well as hypoplasia or absence of the corpus callosum, of the frontal lobes, and of the cerebellar vermis, which, remember, the vermis of the cerebellum is the midline structure of the cerebellum. You can also see holoprosencephaly in a minority of cases, and that just reflects, all of this reflects the defect in sonic hedgehog signaling. In the gastrointestinal system, pyloric stenosis tends to be a problem that can cause projectile vomiting, which contributes to the feeding difficulties. They tend to have congenitally small stomachs. There's an increased incidence of Hirschsprung's disease, which can manifest very early on as failure to pass meconium, and there is also an increased risk of cholestatic liver disease. You're also going to see that there are problems with bile acid synthesis and excretion, which can lead to vitamin deficiencies. In the genitals, hypospadias is relatively common, particularly in males. Females tend to have small labias, both majora and minora, and in genotypic males, there can be sex reversal, which can be anything from micropenis all the way to a female genital appearance, complete sex reversal. Cardiovascularly, the preponderance of these children are going to have congenital heart defects. The most common is that of the atrioventricular canal. You can also see atrioventricular septal defects as well as a patent ductus arteriosus. Renally, there are a variety of malformations that can occur. The most common is renal hypoplasia and aplasia, which ultimately can cause Potter's sequence in these babies, and that's going to lead to pulmonary hypoplasia and generally a pretty poor prognosis. You can also see cortical cysts, hydronephrosis, renal ectopia, a duplication of the ureters, as well as hypo or hyperplasia of the adrenals. Other features that can be seen are anomalies of the laryngeal or tracheal cartilage, which may necessitate intubation. Hypopigmentation and photosensitivity, as previously mentioned. Sleep issues are very common. They also tend to have a susceptibility to infections and poor wound healing for reasons we don't really know yet. So here's the features that you see. You can see that these children all have this very characteristic facial appearance. You can see the anteverted nares. The nares are very apparent just by looking and face at the patient. They also tend to have larger mouth, widely spaced teeth. Some of these children you can see, this child particularly here in slide D, you can see the low set ears, somewhat malrotated. You can also see that all of these children are very fair in pigmentation, and 3 of these children have blonde hair, which reflects the hypopigmentation, but also reflects the fact that the preponderance of these patients tend to be of Northern European descent. You also see here the polydactyly, a very proximally placed thumb. And here is the classic syndactyly. I can't tell if this is a cutaneous or a bone syndactyly of the 2nd and 3rd digit. So here's the nose. So this is a very, very, very classic appearance for SLOS. So note here the very broad nasal root and the anteverted nares, which give the appearance of a smaller nose, and you also see the long philtrum here as well. So here you see the oligodactyly on the left foot. This infant, you can see the slightly anteverted nares, the very long philtrum, and also cutaneous syndactyly of the second and third digits bilaterally. Very large mouth here, somewhat malrotated ears. Here you see webbing between the first and second digits, as well as syndactyly bilaterally. So here's two children. These are brothers. This reflecting the autosomal recessive nature. Neither of the parents were affected. And you can see both their fair complexion as well as anteverted nares. This child in particular has a very wide mouth. Also another thing that I didn't really point out, but you can probably see smaller chin. It's micrognathia. So you can see that in these children. Another problem that you can run into in SLOS, especially as these children get older, is crowding, malocclusion of the teeth. But you can see here that as they get a little bit older, the features become a little bit more difficult to recognize, but that nose remains very characteristic. This you don't bother to memorize this, but this is just a slide showing what's causing some of these features, and the pathogenesis we believe is related both due to the decreased levels of cholesterol from very early on in development. Remember that the maternal fetal exchange of cholesterol really is only significant during the first trimester. So during second and third trimester development, the fetus is reliant on their own cholesterol bioproduction, and therefore, when that is low, they're going to have both the decreased cholesterol, which is going to lead to various issues with the cells, as well as with hedgehog signaling, and then the elevated 7-DHC, which causes oxidative stress, which is going to affect the cells, as well as poor cholesterol transport and increased degradation of HMG-CoA, which again is going to exacerbate the issues with the low cholesterol, because the HMG-CoA reductase is important for cholesterol biosynthesis. It's the rate-limiting enzyme. Developmentally, of course, physically, as mentioned, their gross motor milestones are going to be delayed. The average range of onset of walking is 2 to 4 years. Most of these children are going to track below the 3rd percentile for weight, height, and head circumference, but this can cause difficulties in distinguishing this from failure to thrive, which is also common in these children because they have difficulty feeding. And so it's going to be important in children who are diagnosed with SLOS to distinguish organic failure to thrive from just the manifestations of their disease being they're going to be naturally small. So it's important to have the history on the child to recognize whether or not there's failure to thrive due to poor feeding, or whether this child is just small because of SLOS. And in a lot of cases, it often is both. So the average adult height is going to range from 4'8" to 5'7". These children are going to be small as adults if they make it that far. Cognitively, most SLOS patients are going to have some degree of intellectual disability, usually in the moderate range. Speech is often affected. However, their receptive linguistic skills tend to be pretty preserved and are much better than their expressive skills. Interestingly, as previously mentioned, they tend to have autistic features, and that kind of gives us some insight into what causes autism, and that's been very elusive for neuropsychiatrists for some time. So that's something that's worth studying. But there tends to be autistic features, including hand flapping, abnormal obsessions, insistence on routine, and poor eye contact. However, distinguishing SLOS children from just your general autistic children, SLOS children tend to be more emotionally attached, less emotionally distant than children with autism, and they tend to be more sociable. Those more social manifestations of autism tend not to be seen in SLOS, but the behavioral manifestations, such as the obsessions and the eye contact and the hand flapping and stuff like that, tends to be seen just like in children with autism. For diagnosis, as you can imagine, because this is a biochemical issue, this is an enzyme deficiency, there are biochemical tests that can be performed. So suspicion is going to be based on clinical manifestations. After that, you can get objective confirmation by obtaining plasma 7-DHC levels, which of course are elevated. If there are equivocal results, you can investigate further with genetic testing for DHCR7 mutation. But if you have a classic clinical case and you have elevated 7-DHC levels, then the biochemical confirmation should suffice. Now, when you have a parent who has delivered a child previously, or a couple that's delivered a child previously with SLOS, you can, and you probably will be asked, of course, what's the chance of my child having a future child having this disease? Of course, since it's autosomal recessive, if it's a new partner, if mom now is having a child with husband number 2 or partner number 2, then the chances are quite low because you had to have both parents have the recessive allele. However, if this is a couple's second child and they had the first child diagnosed with SLOS, then the chances are probably about 1 in 4, just like any other autosomal recessive disorder. You can get some hints antenatally as to whether or not the child that's in utero is going to have SLOS. On the quad screen, remember that you get unconjugated estriol. That tends to be low in SLOS. You can also get more extensive diagnostic procedures, which are probably going to be warranted if you have a quad screen that's consistent with SLOS, having the estriol low. You can get chorionic villus sampling and test that for 7-DHC levels, which of course, if they're high, that's consistent with SLOS. You can also get amniotic fluid sampling. Just depends on what route you want to go. So for management, because this is something that we've only discovered recently, is associated with a low cholesterol level, the management is emerging. We supplement these children with cholesterol. That's really the cornerstone of management, and it has been associated with an improvement of symptoms, including the impaired growth, irritability, sleep issues, as well as decreasing their infections and improving their autistic features. However, their cognitive impairment typically does not improve very well because there is some damage that's been done that's permanent. Supportive care, of course, is always going to be warranted. Individualized education plans, typically special education. If they're having refractory feeding difficulties, in many cases we'll have to place a G-tube temporarily. Fat-soluble vitamins should be monitored, of course, because they have low bile acid levels due to the decreased cholesterol levels. And so monitoring their ADE and K both clinically and with labs should be performed, and you can supplement their ADE and K levels as necessary. And then genetic counseling is useful for parents, and developmental pediatric consultation will be useful to monitor and optimize their childhood development. Screening should be done on diagnosis because there are associated issues with the heart and the kidneys. You should get baseline labs. You should get a renal ultrasound, echocardiography, MRI of the brain, and you can do other tests as needed if there's significant abnormalities of the genitals and so forth. And additional consultations can be obtained as necessary based on their clinical presentation. There are new treatment modalities that are presently being investigated for SLOS, including the use of simvastatin, and you'd think that's kind of counterintuitive because we want to increase production of cholesterol, but what this is doing, simvastatin is doing, is reducing the amount of 7-DHC, which we are recognizing as having toxic effects. The reason that this can be useful is because of the fact that cholesterol, when we give it in the diet, it does not cross the blood-brain barrier, and so you're not reducing the amount of 7-DHC in the brain. Simvastatin, on the other hand, does cross the blood-brain barrier, and so the hope is that you can reduce the amount of 7-DHC in the brain. We're still doing clinical studies on this, but the results so far have been mixed. We're also looking at antenatal intervention by supplying cholesterol into the amniotic sac early on, and possibly that may reduce some of the manifestations if we can diagnose this early on during fetal development and intervene before birth. Long term, remember that they do have an increased tendency towards infections, particularly otitis media. They also have an increased risk of skin infections as well as pneumonia. Administration of cholesterol in the form of LDL with fresh frozen plasma can have very beneficial effects during severe infections or after surgery, and so that should be considered. Life expectancy is associated with the severity of internal malformations as well as the quality of supportive care. We don't have any large studies that really plot the life expectancy for these children, just because of the rarity of this disorder, as well as the fact that we're only relatively recently, learning about this disorder and its implications. If you have any questions, go ahead and comment me below. Otherwise, I'll see you in the next section.